Good afternoon, everyone, and welcome to our webinar this afternoon, Good Teamwork Means Better Maternity Care. Thank you all for joining. We'll get started in a moment, but before we start, I'd like to introduce myself. My name's Tracy McCormack. I'm the Assistant Director for Midwifery at the Nursing and Midwifery Council, and I'll be co-hosting with my colleague, Cathy Finnegan, who I'll let introduce herself now.
Hi everyone, my name is Cathy Finnegan. I'm the Head of Strategy and Planning in the Professional Standards team at the GMC.
Thank you, Cathy. I'd just like to welcome our panel members who are going to join our discussion. They'll introduce themselves throughout the programme as we go through, and really excited to hear what they have to share with us this afternoon. So thank you so much for coming, and thank you everybody for joining us. So I will just get started with a bit of housekeeping. If we move through to the next slide. Due to the number of attendees, everyone except the presenters are automatically muted. Please don't use the raise your hand feature because we are having questions in the Q&A, and feel free to use that function for any questions and comments. We'll try to answer as many of the questions as we can, but due to the numbers attending, we probably can't answer them all, but the team will review everything you tell us. The session is being recorded and uploaded to the NMC website afterwards, and we'll be sending the link. Attendees can switch on live captions in Teams for accessibility. Under the More, 3 dots, select either accessibility or language and speech. Thank you. Next slide, please. Thank you. So we'll just do a bit of introduction before we get into our discussions. So this is a collaborative focus on maternity. And we wanted to work together as the GMC and NMC because we know that multidisciplinary working sits at the core of maternity care, and that doctors, midwives and nurses work closely together. As such, we wanted to work together on this project to align messaging for healthcare professionals about the application of relevant professional standards. And we produced resources focused on maternity care, and that was to create resources in line with inquiries and reviews, including the most recent independent review into maternity and neonatal services in East Kent. And these have shown that professional standards are not always met in maternity care, and that multidisciplinary team working being a recurrent issue. And as a result of that, patient care can suffer. Our respective maternity resources highlight the relevant professional standards that apply in the delivery of maternity care. Next slide, please. So we collaborated with a lot of people to do this work, and these are some of the people we spoke to. So we spoke to organisational representatives, doctors and midwives, equality organisations, healthcare regulators, patient representatives, individual doctors and midwives. Now I'm handing over to Cathy.
Thanks, Tracy. So during the engagement on these resources, we received support for joint working between the NMC and the GMC. On multidisciplinary team working, we heard about the importance of respecting and valuing every member of the team. We heard about the divisions that can result if colleagues are perceived to have different agendas relating to patients' care. And stakeholders also expressed the importance of continuity of care for patients when handing their care between healthcare professionals. And there was particular emphasis on this for patients who might be experiencing perimental mental health issues. On communication with patients, we heard about the importance of establishing trust with patients and encouraging them to speak up if they have concerns. So those we spoke to emphasised communication barriers. So, for example, patients whose first language isn't English appear to sometimes be at a particular disadvantage with this. And we had some support for what we might do to tackle communication barriers in our respective resources. And then there was also support for us to include advice for staff supporting patients who've been affected by pregnancy loss or baby loss. On the theme of escalation, we heard about the importance of delegating safely and the need for professionals to speak up if they lack the skills or the competence to carry out a particular task. Stakeholders also told us about the need for staff to feel empowered and supported if they've identified an issue that could be putting patients at risk, and as well as the crucial role that leaders play in facilitating a supportive environment that enables this. We also heard support for advice on the professional duty of candour and how professionals should handle instances where things have gone wrong. We heard that the actions of professionals following an incident can compound harm if they're dealt with badly. And we also heard about inequalities in care and access to care that might be faced by ethnic minority patients, patients for whom English isn't their first language, patients with learning difficulties, those living in deprived or rural areas, and trans and non-binary patients. So what next, and what did we do once we had heard that? So we wanted to use what we'd heard to create resources that would be helpful. And we decided that the best way to do this was to create our own individual web pages. These are aligned and linked so that users can easily navigate between the pages, but they reflect the fact that we us and the NMC, each have our own registrants with different roles, responsibilities, and professional standards. So our resource takes the form of an ethical hub page, and this explains how the professional standards, including good medical practice, may be applied in maternity settings. So the hub doesn't set new duties of good practice. It gives advice on how the professional standards might be applied. And it addresses the areas that we heard about in engagement. So it's split into a number of different areas that you can see here. So we have a section on team working, we have a section on communication and addressing communication and language barriers, as well as an accompanying section on treatment options and supporting patients to make decisions. And then we also have sections on escalating concerns, the importance of candour, and tackling inequalities. As Tracy mentioned, we know that maternity care has been the focus of several reviews, inquiries, and national surveys, and we've referenced excerpts and recommendations from reports of those throughout the page. We've also included references to the professional standards that apply to the advice that we're providing, and the page also signposts to useful advice and guidance from other organisations too, such as those listed on this slide. I'm going to just pass back to Tracy now to talk a little bit about the NMC's resources.
Thank you, Kathy. So for the NMC webpage, our resources were case study based. And similar to our previous campaigns on partnership working in maternity care, leadership and holistic care. We heard from 6 midwives, a student, 2 doctors, 2 women, and a partner as part of the work. And the themes covered by the case studies, as you can see, align with the GMC's ethical hub based on our joint engagement. So for team working, we looked at areas such as handover, learning together, and involving students. For communication, we looked around consent, treating people with respect, and psychological safety. For escalation, getting the right care at the right time, and professional duty of candour. And for inequalities, it was about understanding communities and personalising the care and cultural safety. And we also draw the link between the case studies and the relevant parts of our code and standards, and link to resources from the GMC and other organisations. Thank you. I think that's the end of our presentation now. So if we bring the slides down, we're going to welcome our panel to have discussions with us. So the first people that we're going to speak to are Paris and May, and they're Cultural Safety Midwives from Sheffield Teaching Hospital. I'll hand over to you to introduce yourselves. Welcome, Paris and May.
Hi, yes, my name's May Stevens and I work as a cultural safety midwife at the Jessup Wing in Sheffield.
And Paris?
Thank you, Tracy. I'm Paris. I used to work as cultural safety midwife with May. I now work as matron for perinatal health and wellbeing services, but work very closely still with May and all the cultural safety work. Thank you for having us.
Great to have you here. Thank you. So I've got a few questions to understand a bit more about your work, and maybe my first question will be to you, May, if that's okay. What does a cultural safety midwife do, And can you tell us a bit more about your work?
Yeah, so the cultural safety midwife role was introduced a few years ago in response to the increasing evidence about disparities in maternity outcomes by ethnicity, both the clinical outcomes and also the way women feel about their care and the experience they have through the maternity journey. And these disparities should be avoidable, and we find them unacceptable. So the role was introduced to try and address some of that. So the aim of the role is to do work within our organisation to improve outcomes and experiences for women from ethnic minority backgrounds. And in practice, this is a really diverse range of duties on a day-to-day basis. So a really big part of the role is education of our staff. We have developed and delivered study days and other ad hoc training, both for midwives and other professionals, teach on staff inductions as well. And we're always available for advice to staff and consultation about how they might be able to improve things in their areas. I also do a lot of work with interpreting and translation improvements with the trust, so improvements to guidelines, acting as a stakeholder in work with the contracted interpreting supplier, audits on interpreter use, and we also have a link worker service as well for women who speak Urdu, Punjabi, Arabic and Roma and Slovak. Have a role in quality and safety, so incident investigation, regular attendance at incident review meetings to consider if inequalities due to ethnicity could have contributed. I engage with communities, looking for feedback, for example, in focus groups, do co-production projects, and we also have run specific funded projects, have been successful in getting funding from hospital charity to run tailored parent education classes, for example, and I also have a small role in FGM improvements as well.
So quite varied and a lot of different areas to your role. Just before I hand over to Paris, I've just got a further question. So Paris said that you used to work together. So you said do you work as a team? Are there a few of you that do the role?
So it's one full-time equivalent and it's a job share. So me and Paris used to share the job. Okay. I am currently, the other half of my job share is currently vacant. So I'm currently doing it by myself, but yeah, it's a job share.
Thank you. That's really interesting and a lot going on. So thanks for sharing that. And Paris, a question for you. How does this work benefit women, babies and families, especially those with additional needs? And how do you help make women feel psychologically safe?
Yeah, so I think at its core, really, the work improves women's experience of their care so that they can feel seen, heard and respected, rather than their care being something that's done to them. So a key part of it is psychological safety. So we support this, as May said, through education, helping staff to think about how they interact, how they communicate and how they take individual needs into account. So it's ensuring women feel listened to, not judged, and that they're able to be active participants in their care. But it's also about more than individual interactions. It's about how the services are designed. So many of our systems weren't originally designed with the needs of women from the global majority or those with additional needs. And in part of our role is working with operational teams and across the system to shape the services so that they're more inclusive and accessible. So culturally safe care helps to build trust. So not just in the individual practitioners, although that will obviously improve that care, but in the service as a whole. And that trust is key, particularly when supporting women with additional needs. So for example, if we think about mental health, we know that not all women will describe their experiences in ways that fit neatly into standard referral pathways. So we work with teams to think about how lower thresholds for a referral and not relying on specific language or labels, but really understanding what women are telling us in the context of their specific lives. And as May said, a big part of the work is through listening, so through community engagement, focus groups, and using that insight to inform the project work that we do so that it has a direct impact on women and their experiences and their care. And we feel that when women feel psychologically safe and understood, they engage more, and that's where we see the biggest improvements in outcomes and experience. So there's already many fantastic interventions and pathways available to support women, but access and engagement doesn't always reflect the needs and diversity of our birthing communities. So a key part of our role really is to break down those barriers and bridge that gap. So it's not about rewriting services completely or redesigning them all completely from scratch, but it's helping them and supporting the people that deliver them to be able to make them more accessible and more inclusive, and then ultimately more effective, and so that all women can engage and benefit with the care that's available, and therefore sort of improve their experience as a whole.
Thank you. And I have another question for either of you to answer. Who are some of the different professionals you work with? I think you've named a few, but if you could just give a few more of who you work with, and why are these good relationships with them so important?
Yeah, so firstly, it's really important because the families that use our service, they experience it and rate it as a whole. They're not just, when they talk about their experience during pregnancy and birth, they're not usually just focusing on the midwives or the doctors. They're sort of sharing the way it made them feel overall. So we all need to be working from the same values. We can't just be concentrating on one profession. And even though I'm a midwife, I can't just change the maternity service through midwives. The maternity journey includes, for most women, contact with midwives. Maternity support workers are playing an increasingly important role. Doctors, both obstetricians, anaesthetists and paediatricians, sonographers, and then for some women, physios, mental health professionals, neonatal nurses, theatre nurses, and the research that, you know, what we hear through research or feedback from women's experiences, when women share their feelings of being and their experiences of being treated differently, they're not exempting any particular professional group from that. For example, if you read the Birth Rights Report into Racial Inequalities in Maternity Care, there's experiences with sonographers that are mentioned, there's experiences with health visitors. All of those things are picked out by women. So it's important that every profession in the maternity system is aware of the disparities in maternity care and what they can be doing about it. So what they can be doing to address the systemic barriers to care, like Paris was talking about, but also how to examine and address their own unconscious biases, which is the way people's individual care relationships affects the outcomes. So the main way that our role directly impacts on this and touches on other professional groups is that I do provide a lot of training to other staff groups as well on best practice for interpreting, on cultural safety, including unconscious bias, microaggressions, those kind of things. And I'm available to all professionals within obstetrics, gynecology and neonates, which is our directorate in our organisation, for chats about things they've noticed, for helping them improve certain services, for getting feedback for them, all those things.
That's really, really helpful. I just had a quick question. What the role that you are doing is so important. And I was wondering, is this a role that is replicated in a lot of other organisations?
I don't think there are many people whose job title is the same as cultural safety midwife, but there are a lot of organisations, particularly in areas where there is a higher level of ethnic diversity, who do similar things to us. Their portfolio, their work streams might be made up slightly differently, but the idea is kind of the same. Some places call it EDI midwife, specialist cultural liaison midwife. There are various guises and sort of ways that they've added this into the structure, and sometimes it's part of a wider portfolio, like a matron for inequalities or something like that. But yeah.
Okay, that's good to hear. It's good to hear that even though it's called something slightly different, it's something that is now being embedded across all organisations, because it is a really important part of how we care for our women and families. So thank you so much for sharing today. I will hand over to Kathy.
Excuse me. Thanks, Tracy, and thanks very much, Paris and May. I'm really pleased now to welcome our next panellist, who is Dr. Tony Kelly, who's from NHS England, and Tony gave us a lot of support as we were developing our resources. So, Tony, can I ask you just initially to say a little bit about who you are and introduce yourself, and then I have some questions for you.
Yeah, of course. Thank you. And it's lovely to be here this afternoon, and great to see so many people on the call to hear about this amazing resource that you've developed. So my name's Tony Kelly. I'm a consultant obstetrician. I work down in Brighton. I've been down there for the last 20 odd years. They still allow me onto the labour ward occasionally. But my main job now is working as one of the national specialty advisors within the maternity and neonatal programme in NHS England. And I've got a sort of a reasonable portfolio of different projects, but one of the key areas that I've been working in over the last 10 years has been within the cultural and leadership space. So it was great to have both the NMC and the GMC as sort of key strategic stakeholders on our steering group over the last few years to help support that work. So that's been the main role that I've had that's sort of relevant to this.
Great, thank you very much, Tony. And I don't know if there's, can you tell us a little bit more about sort of what that work with the maternity and neonatal programme involves, please?
Yeah, of course. So we were very mindful. I mean, my background before I came into this role specifically, I've done a lot of work in quality and safety over the last sort of 15 years. And we're very minded that we spend a lot of time sort of solution bombing the space, particularly nationally in the perinatal space, with lots of care solutions, therapies, intervention processes. But what we were very keen to ensure is that we weren't losing sight of the importance of the cultural sort of foundations and frameworks that we need to make those interventions work effectively. So what we did was developed a national programme to support every maternity and neonatal provider across the country. And that work was basically broken down into 4 main phases. The first one was to take the group of clinical leaders from each service, and unusually what we were trying to do here was not necessarily develop them as individuals, but develop them as a team, specifically looking at people who were sat at operational levels. So we took consultant obstetricians, midwives, neonatologists, and operational managers, which were originally sort of termed as a quadumvirate or a quad. And they went through a development program which was part face-to-face, part online, involved developing them, enabling them as a group, trying to get them to think about how they could support and promote the type of shift within local cultures that we were hoping to see. Following on from that, we then took all services through a structured safety culture survey, similar to one that we'd run about 4 or 5 years prior to that. And then following the survey, the third phase was developing a collection of what we called culture coaches to really support the clinical teams to make sense of what their culture survey had shown them. And from that, develop an improvement plan around how they wanted to make focus on particular areas within the work that they were doing. And this wasn't expected to be things that would necessarily be implemented across entire services. This is very much things that would be within the gift of those perinatal teams to change and adjust and work with. And so that work ran over around, I think, from beginning to end, slightly marred by some delays that we had for a few things along the way. But the programme itself took about 2.5 years. And the final phase of it finished towards the end of last summer. And that was the main work that we did. We've also done, we're just finishing off some work that we've done on a similar approach with regional teams and LMNSs to try and give them some support to try and enable the right sort of safety cultures within their organisations, which in turn will then support down into the organisations themselves. So that was the main work that that programme was undertaking during that sort of period of time.
Right, thank you very much. That's really, really interesting to hear about. And I think that that point about sort of making sure that the culture and the environment is right to make interventions stick is really interesting to hear about. Can you tell us a little bit more about why it is that positive culture and leadership are so important to delivering the best possible maternity care?
So I think there is, I suppose the anti-question to that is, well, you know, if we don't sort of address or try and enable these cultures, what tends to happen? And I think what we've certainly found with a number of the sort of policy vehicles that we've used nationally over the last few years is a number of these types of processes get sort of dropped into services with an assumption that just by being sort of pointed towards what needs to happen, that change will occur. Whereas what we've certainly found, and certainly the outputs of the work that I mentioned just before, the enablers that have then sort of gone from where we've seen these positive cultures and very sort of visible leadership and committed leadership within these teams on the back of the programme, we've certainly seen an acceleration of quality improvement changes and an embedding of the right cultures within those teams. But what we've found was that the things that made the shift in the clinical processes much more effective was when that process was enabled by visible and committed leadership and a stability in those leadership teams. Whereas the reverse being true when we found that despite best intentions, that leadership teams were not as visible. There was high turnover within those posts, which is relatively common because a lot of people who are in these clinical roles are doing leadership as an add-on to their clinical job, and the pressure of the roles that they are, the turnover is relatively high. And so what we found that even though we'd enabled a number of these leaders to become quite adapt and have very great cultural insights, they may then move out of those leadership posts. So we sort of disabled processes. But importantly, those leaders needed protected time, capacity, and needed to be well resourced to be able to support the clinical change that needed to happen. And through that stability, I think what we were finding was that within those clinical teams is the context of the conversations that were coming up to leaders from the clinical teams on the shop floor shifted. And so it shifted away from talking about lack of resource, lack of workforce, and moved into talking about concerns about individuals, looking at trying to understand how we could make the workplace more psychologically safe. And I think that ability to open up those spaces, create that psychological safety, which in many ways, in the way that we use it within our workplace, it's much more around social psychological safety. So safety within teams, both to feel comfortable to speak up, but also to be able to support each other and call out behaviours when they're certainly not moving in the right direction. And all of this enablement, regular engagement, continuity and follow-up around the way we were doing seemed to be the perfect springboard for real quality improvement to take place, but more importantly, to allow people to be able to step back and sort of think about how they could make where they're working somewhere that had the stability and safety they needed to be able to support each other. Certainly over the lifetime of the programme, when we were running it, we were coming off the back of COVID. We were going through a number of very challenging times from a workforce perspective with shortages, high levels of sickness, various rounds of COVID and flu, junior and what were then junior, now resident doctors and training doctors, industrial action, along with consultant industrial action. So it was a very challenging time from that perspective. And when we have this sort of cultural stability, we were finding it was really helpful. And I think certainly having the opportunity for people to act as those central drivers, certainly for midwifery leadership, really good capability amongst our leaders and really good engagement with the front line, we were finding that we were seeing everyone was getting further quicker but doing it together and sort of seeing some sustainable change. And then the last sort of really important element of that is that the system and regional teams are on board with the way things are moving, so it doesn't become very much something that only happens within clinical spaces, but that enablement's happening all the way up through organizations. And I think it sort of becomes slightly self-sustaining, but sadly the antithesis of that is in areas where we're not seeing this sort of same level of psychological safety, we're not seeing the stability, we're not seeing the same levels of improvement that we would want to see.
Thanks very much, Tony. And I think you've talked about how the that culture and that sort of very positive team working was something that helped through sort of a challenging time externally. I wonder if you can tell us a little bit why this sort of importance of really, really positive and strong team working is particularly important when things perhaps are going a bit wrong, when women and babies are in a condition that's deteriorating, or when things are particularly challenging. Is it particularly helpful in those sorts of circumstances?
I think that's probably one of the key areas for us. So the other part of my work has been overseeing the development and the implementation of a new national maternity early warning score tool. We've also put in place with BAPAMA the tool, a new newborn early warning track and trigger tool, so the second version of that. And we're about to go into implementation with a new intrapartum fetal monitoring tool of a similar nature. And a lot of the focus, again, with these tools is very much put them in place, think about how they can identify problems more readily. But actually, the areas that we fall down sort of perennially, when you read reports like Embrace particularly, is the information is understood by the person who's involved directly with that clinical care, but what they're not getting is they're not enabled to escalate effectively to colleagues either within their own team or across teams. So midwife to midwife, midwife to doctor, doctor to doctor. And we have various tools that we use, things like SBAR, which are great for communication. But actually, most of these processes require some degree of cultural underpinning that everyone is sort of very understanding of, to ensure that you have a culturally competent conversation between two healthcare professionals. One of the tools that we've been using quite widely across the country is one called Teach or Treat, which is a great example of this. So the necessity of that is, if you and I were having a conversation about a concern about a woman or a baby, I may be coming to you with concerns. There would be an expectation that, having listened to those, and you felt that there was an opportunity for intervention being required, you and I would go and treat the problem. Whereas if you felt that there wasn't something that needed to be addressed there and then, you would then help me understand why and what you felt was necessary in that space. So a teaching element to it. And that process can be incredibly positive and allows people to come without fear, without the sense that they might get belittled or there might be sort of retribution for raising something that wasn't necessary, which can be seen in areas where culturally competent conversations aren't occurring. But to embed that process, what you can't just do is say, we're going to use Teach or Treat. What you need to do is you need to ensure that people understand what the behavioural expectations are within that space. If you feel that you and I haven't had the right level of conversation, that you or I have the opportunity to go and speak to someone, say, well, that didn't go as planned, and therefore there's a way of trying to ameliorate the behaviour on one side or both. And we've developed a set of tools called Moments, which we're using and developed and are implementing through our patient safety collaboratives through the Health Innovation Networks, which give clinical teams an opportunity to sit down as a small group, discuss the intervention they're trying to use, but then think about, well, actually, what are the cultural values that underpin this intervention? So what would it look like if it went well, rather than just if it happened? So how could I walk away ensuring that you and I are dealing with each other in an appropriately civil way, and that actually we both have an understanding of what the inputs and outputs of that are? So to just think about deterioration as a technical rather than a socio-technical skill, I think, is where we can fall down. And sometimes we just drag and drop solutions from another hospital. So, we've just heard about some magnificent work at Sheffield. it may be that we take that work and try and implement it somewhere else. But if actually we haven't got the right level of the environment in which we're putting that into isn't ready for that, hasn't been primed in the right way, then you may end up with people in similar roles to May's that we've been hearing about in my organisation, for instance, that we may immediately get a degree of frustration because we haven't prepared the environment, the cultural frameworks aren't there to actually make that work well. So I think it's incredibly important both to allow implementation of these interventions, but also embed and sustain them. And if we do one without the other, then we tend to fall down.
Really fascinating. Thank you, Tony. And I'm sure that that will generate some ideas and some questions that we can come back to. But for now, I'm going to pass back to Tracy to bring in our third panelist.
Thank you, Kathy and Tony. I'm delighted to welcome Imelda. Imelda is a service user rep from Northern Ireland, and she's also a member of the Midwifery Strategic Advisory Group. I'll let you do further introductions and tell people a bit about yourself, Imelda.
Thank you, Tracy. So yes, as Tracy said, I'm a service user from Northern Ireland, and I got involved, I suppose, back in 2021 after I had a career, I suppose, before that, previous to 15 years, and I had my two little boys along the way. They were 2 and 4, and in 2020 I suffered a miscarriage and an ectopic pregnancy, and what the first one I thought broke me, but when I had the second, it definitely did. There was loads of feelings in the hospital at the time, making something that was probably really difficult even more traumatic. Lost notes, lost tests, repeated hospital stays, and because of COVID restrictions, it was all done by myself. There was no other support with me. You're so vulnerable, and it was not a nice place to be. But all the time I was there, I kept thinking about other people. I never found my voice when I was in I was going to say the hotel. I only wish it was the hotel. When I was in the hospital, and I never spoke up, and I didn't advocate for myself. And I came away just wishing that nobody would have to feel some of the things that I felt that were unnecessarily. Yes, there was grief and it was a difficult situation, but it just didn't have to be so more traumatic. So an opportunity arose to join a service user group within Queen's University School of Nursing and Midwifery. It's called a Patient and Cares Education Partnership Forum. I kind of thought, what could I bring to the table? What difference can I make? But I remember thinking to myself back in that bed, if I could make the difference to one other midwife, to put themselves into somebody's shoes, that it would make that easier for somebody in the future. So I got involved with Queen's, and we do everything from the co-design and true meaningful co-production. We've worked on psychological safety protocols. We are involved in undergraduate assessments. We do OSCEs. We co-facilitate lectures. So there's a breadth of work that we can get involved in. And then obviously it's led to other opportunities, such as joining the MSAG within the NMC. So I suppose that's how I got into work as a service user, Tracy.
Thank you so much for sharing your story with us, Imelda. I'm really sorry that was your experience. The pandemic was a difficult time, but it doesn't excuse the experience you had. So I'm really glad that you found your voice and you're using it to move things forward. But can you just give us a bit more information on why it's so important that the voices of women and families are embedded into how services are designed?
Absolutely. I suppose families and women are absolutely at the heart of, the maternity services. So they should be at the heart of it, and their voices listened to. And it shouldn't just, be a nice to do. If we want patient care that's truly person-centered, it's going to build trust in maternity services. And I suppose at the minute, there's such scrutiny over what's going on, and everything's been shown in such a negative light. It's in the spotlight. And I think it's good just to get to be seen to be working together with service users, to build that trust back out again, because there is so much great work in there, and I suppose it doesn't get shouted about enough, and it doesn't get celebrated. And I suppose from me to everybody here that is a healthcare professional and works with maternity services, thank you. But I suppose there does need to be more work in terms of, you know, asking for the feedback. Because if any service we have, if it's customer service, it's hospitality, we look for feedback for improvements, and also to celebrate. So I think if we ignore it, there's going to be more dissatisfaction. We're going to have more cases that require more medical intervention, but why not have families included, and lower the complaints, prevent them complications, and I suppose just overall improve satisfaction, build that trust. And also what's important is your own job satisfaction. You know, if you have a happy mother and a happy family, you know, you're proud then of your work. And I think it's kind of like a full circle, doesn't it? Comes right back round.
Thank you. Yeah, it's very important to get that feedback, isn't it? And co-production is key. Thanks for sharing that. So why is it important for midwives, doctors and others to listen to women and families and respect their choices?
So yeah, listening and respecting, I suppose it's the cornerstone of safe and ethical and the high quality care that we all expect to receive. And I suppose it should be at the forefront, and most of the time it is at the forefront of the daily clinical care, and just not being separate from it. Because we all want our care to be effective and compassionate, particularly within maternity services. And we're all human, and we know if we're not listened to, we don't feel respected. And that's no different, I suppose, in a maternity setting. And this can really protect the safety of women and babies, because women know the subtle changes in their bodies, and if they're not listened to, then they will shut down. And it creates that environment of just respect and making you know, choices that are right for you. I suppose another example for me was I wasn't listened to during the second birth of one of my wee boys, and I was being induced. I had high blood pressure. I was pre-eclampsia. I told her I needed to push. I was just started on the drip, and she was like, "No, you don't." And I was like, I really feel like I have to. And she says, "No, I can't examine you. We're back in 4 hours." And within 35 minutes, he was delivered. What followed was a blood loss of 3.5 litres. It was complete carnage. You know, it became a birth trauma. It became traumatic for my husband. And, you know, I actually, when I felt unwell in the bed, after saying I needed to push, I started to feel unwell, but couldn't speak up to the registrar who was stitching me at the time, because I thought, well, nobody's going to listen, are they here? So I kind of shut down and passed out, and then I lived to tell the tale, and everybody was okay. But I do think, you know, if I had been listened to, maybe some of that trauma would have been avoidable. So yeah, I suppose if a woman's just feeling dismissed, she's going to shut down. She's going to hold back potentially important information, and she might also not avail of services that are there to protect, to keep her and the baby safe as well. And women obviously are from all sorts of backgrounds. They've got their own values, they've got their own preferences, and they've got their own lived experiences. And I think we need to combine all of that with the medically sound knowledge of all the professionals and all that invaluable knowledge that they have, but combine them with their preferences and their values, and it becomes, I suppose, a whole joined up holistic care, which is obviously better outcomes for mother, baby, and their families. So listening it's like anything, and I have to remind myself, this quote is, when we have 2 ears and 1 mouth, to listen is twice as much as we speak. And I know I'm blathering on here today, but you know, something that's really basic and powerful and a way to connect to another person is just to listen.
Thank you so much for sharing that. And thank you for sharing that experience. I think that is a prime example of why listening is important. And that's really sort of giving us something to reflect on here today. Really, really important information that you shared with us there. Thank you very much. So thinking about good teamwork now. So how does good teamwork between professionals benefit women and families?
So Tracy, I think good teamwork is going to, I suppose, have an overall impact of the experience that women and their families have. And I suppose no matter what the setting is, if it's out in the field playing a game or if it's own family home, when communication is clear between us all, everything just works better together and as a team. So making sure people are working together, information isn't getting missed, and that people receive effective care, or any concerns, I suppose, can be dealt with, but can be dealt with, I suppose, more effectively and quickly done. I think what's important that when people can see good teamwork, you know, when places are organised and the care feels organised and professionals aren't openly criticised. And I've seen that where, you know, there's power imbalances, you know, as May says, we see maternity care as a whole. We don't see anything separate. We don't see midwives or doctors or obstetricians or the anaesthetists. Everybody's part of one team, and that's the way we see it. But when on the side of the bed, you can see sometimes that difference of opinions. You know, you may have that, but that, suppose, then breaks down our trust, I suppose, if we can see things that are going on along the side. So and I think if you're able to speak to somebody or put somebody down or openly criticize them, then to me that's not showing kindness. And if you can't show your kindness to your co-workers, you know, what's that stopping you from maybe not making the right decision for me? And again, I would just question that. So yeah, I think working together, good teamwork. When we have those skills all combined together, looking after our emotional needs are met, when we have, I suppose, a more joined up holistic approach, then we're going to have probably less trauma, you know, coming away with improved mental health, at least, you know, when we know somebody actually cares. So ultimately, I think just good teamwork is important for safe and consistent and compassionate care. I suppose that's just really at the heart of it, and good teamwork just allows that to happen.
Thank you. And you said something that really resonated with me, that as a service user, you just see a maternity team. And so we have to work as a team, because that is what you see and that is who you're expecting the care from. So yeah, that's really important and really valid point there. And something that we should all be remembering in our work, that you see us as a whole, not as the individuals. Thank you so much.
You're welcome.
So we have come to the end of our panel discussion, and we did want to take any questions. There aren't any questions in the chat at the moment, but I'm going to hand over to Verena now, who is going to bring some questions to the panel.
Thank you, Tracy. Just a question or two, which in the first instance, one really for, I think, May and Paris, and it picks up on Tony's point about priming and preparing the environment. And I was wondering, from your point of view, what have you found, sort of thinking back, what were the effective things to do about priming and preparing the environment for the work that you do?
Well, I started this work from absolutely nothing 5 years ago. So there was nothing like this in our organisation at that point. So I had the opportunity to create things from scratch. And at that point, it was just me doing that. I didn't have any other resources around me, just my voice, really. So I'd say the first step is trying to make people understand what the problem is, why there is a problem, and what they have to do with it. And in the area that I try and make changes in, which is inequalities by ethnicity and racism, basically, there's a lot of groundwork that has to go into that before you can even start to have the conversations about what we're going to do differently, what tool we're going to introduce, what pathway we're going to introduce, because it's a really difficult subject to talk about for a lot of people for different reasons, either people who've been on the receiving end of racism, and on the other hand, a lot of staff members who have come into the profession with the best intentions and really don't like to hear that they might be responsible for causing people harm. I think that's the case in a lot of situations at the moment with the reports that come out about maternity care and, you know, the criticisms in the press and things like that. It's horrible to hear that you might be causing harm when you come to work actually to care for people. So anyway, I think it's, for me, the groundwork is a long-term process of trying to break down why it both is personal and it isn't personal. Like, it's not your individual fault, but you have a personal responsibility to fix it. And I'm not here to criticize you and say that you as an individual have caused an individual harm, but that we're all part of it. So it's like winning over hearts and minds, getting people to understand the rationale for it before you can really do the work. And I've been in the post 5 years now, and more people trust me with ideas and want to get on board with work that I'm doing. I don't know whether you've got anything else to add, Paris.
I was just going to say, I think it's really important when you're priming to have the right people in the space. So everybody's got their area of expertise, and knowing the qualities that other people and their point of view and service users are going to bring to that. You need to start from the right place. Otherwise, a thing that May and myself always say are, we could put this intervention in place, but actually, does anybody want this? Is this what's wanted? We could spend ages developing a completely, wonderful service, but if that isn't actually meeting the need, or isn't actually what anybody wanted or needed, why have we done this? We always sometimes think we have the best ideas or we know best. So having the right people around to start with that basis, I think it is the best place for priming, I'd say.
And different people can reach different audiences as well, I think, and have really good connections in different spaces, both different communities, different service user groups, but also different professional groups as well, to bring it back to interprofessional working. It's been really crucial to find the people who want to be on board, the sort of leaders in the individual professional groups. They haven't got a cultural safety doctor or physio or whatever, but some of them really are passionate about it and really believe in it. So it's been really useful to have those sorts of people around the table as well.
Thank you very much for that comprehensive and detailed replies. Much appreciated. I've got a question coming through. Really, this one's for you, Tony. It's building on, leaders helping to create positive working environments and so on. But it's a question specifically around how have you evaluated the success of your work?
Perfect question. So we did it in three. We did 3 different sets of evaluations along the way, because we were very much we worked with 2 key external partners. So one that did the development and the implementation of the quad program, and then we worked with another partner on the development of the culture coaches and the sort of the improvement plan development, and then we did a third, and so that they did those phases of the program, and then the last one we went out to an independent evaluation, which we used the University of Birmingham, who undertook an evaluation to sort of see what the through line was, and which actually got the sort of the high level stuff from that evaluation got featured in an article in the HSJ Health Service Journal 2 or 3 weeks ago. And unfortunately, they focused very much on the negativity of that evaluation, which was not unsurprising, but quite difficult. But what the evaluations showed us, and I think what a lot of the learning showed us, and some of the points I was making earlier were drawn from that, was we were able to really see the value people placed in being able to work effectively as quads, and really the power it had of working as a team rather than just trying to work as individuals, so an understanding of what roles were. There was a real sense of enablement coming from the problems being looked at a local level. So I think what we were just hearing about the idea being, is it something relevant to that team at that point in time? And the culture surveys and the sort of the debriefing from those surveys allowed people to create those plans really, really well. But what the evaluation also showed us was, if the external organisations that we're working with aren't signed up, or more importantly, the trust level executive aren't signed up to what the department or the directorate is trying to do, then that becomes very disabling. And so we had a number of teams that were finding that they had great ambition, but actually weren't being supported from an executive level. And then one of the biggest problems that we found was this high turnover in clinical leadership positions, which was very disabling to the way that the work was going to move forward. And ironically, one of the other problems that we had was a lot of senior midwifery roles are full-time in leadership and managerial positions, whereas doctors traditionally don't do those roles full-time. And so a lot of the expectation and sort of a lot of the load of the delivery of the improvement work tended to shift onto midwifery shoulders, which then made it very difficult, because those individuals had wider roles than just trying to deal with the cultural improvement work. So that again became quite disabling. So we did quite a lot of evaluation to try and understand it. We certainly found that in some ways the initiative thicket, I suppose, that we create nationally with so much expectation on services adds to the problem. So we're not allowing people space and time to understand what they might value as being problems locally. And it's so encouraging to hear what the guys in Sheffield are managing to achieve by creating those spaces in which the teams are able to sort of talk more openly about what's important to them. And I think certainly from work we've now done, we're trying to find out and understand how we can do that better with future pieces of work.
Thank you. Tony, the questions are starting to come in now, and we've got one which would need a really, really brief reply, because it's from Becca, who's a GP, and she says she can see huge differences between trust cultures, and they've seen a great motivated workforce and so on, but it's whether you've used your rotating resident doctors to spread leadership and culture change between trusts, and can you see a benefit or potential there?
I think what we hoped, if I'm honest, that we would get from the work that we were doing was that there would be this sense of spread of expectation and spread of understanding of the value of creating these cultural spaces. And, particularly with doctors who are rotating between units, there should be a familiarity of some of the way in which we work, rather than just what we're doing, but how we're doing it. Whether that's really happening, I think, is much harder to understand. My own sort of sense of slight disappointment of the permeation of the national ambition down into the organisation, down to individuals who are working in teams. I think the reach of that work has been more limited than we thought it might be. But I suppose that's an inevitability to a certain degree. But I also think what we are seeing is teams are becoming more cohesive in a way that there's an expectation about behavioural normality, so that when people are coming into those teams, what you're aiming for is that they're more welcomed in, but there are behavioural norms that people are expected to adhere to in the way that we behave to each other, with each other. And that sort of sense of citizenship that you get when you work in a really effective team, I think, is becoming more evident. But I think we've still got a fairly long way to go in that way.
Thank you, Tony. I mean, that is a very good way, I think, to end. There's good work going on, and there's lots of work still to do. So I'm going to hand back to Tracy, because it's been a very interesting discussion, fascinating insights into the work. And I think we could have gone on for another half an hour, but we've run out of time.
We definitely could. It's such a fascinating area to discuss. Just shows that good teamwork does really mean better care. So thank you for all the work you've done. Thank you for your participation today, and thank everybody for coming. I think we'll sign off now and have the good rest of the afternoon. Thank you. Bye-bye.
Thank you.